Hello, class. I'm Freddie. Case study presentation is on type 2 diabetes. So, this patient is here for a routine checkup, but the fatigue she's experiencing, while subtle, hints at the need to revisit her diabetes control. She's mostly adherent to her metformin, but small lapses in her current glucose reading suggest we need to dig a bit deeper. This visit gives us a good opportunity to evaluate her management and consider next steps. Her view of symptoms was pretty benign, no classic hyperglycemia symptoms or concerning complaints that would push us toward complications. The fatigue seems more likely to be multifactorial and not directly tied to her diabetes right now. Her personal medical history is fairly straightforward. No surgeries, and a 5-year history of diabetes. Family-wise, there's definitely a pattern of cardiometabolic risk, which reinforces the need for proactive prevention, especially around cardiovascular health. Current medications, she's taking metformin 1,000 milligrams twice daily. She has no known allergies. Social history: does not smoke or use recreational drugs, does not consume alcohol. She lives with her spouse and 2 children, employed full-time as a high school teacher. Here are some objective findings. Vital signs, pretty benign. Physical exam, pretty benign. Okay, so this is an abbreviated overview of the most clinically relevant lab findings for her visit. We're focusing on values that inform glycemic control, renal function, lipid status, and possible secondary causes of fatigue. Everything here helps paint a broader picture of how well managed or not her diabetes currently is. So we have A1C 7.9%, sodium 139, potassium 4.3, BUN of 14, creatinine of 0.9, ALT 22, AST 24, hemoglobin 13.5, hematocrit 40, WBC 6.8, platelets 245. We have LDLs 142, HDL 42, triglycerides 178. Sorry, so weird abbreviations for triglycerides. We also have like kidney functions. Okay, this slide pulls together what we've gathered so far. Her A1C is elevated. She has signs of nephropathy. And although her fatigue isn't alarming, it helped prompt this deeper look. The absence of symptoms or physical findings doesn't mean the condition isn't evolving. This is a great example of how lab trends and patient history guide us even when the exam is relatively benign. Given her A1C of 7.9%, she's beyond what we typically manage with metformin alone. Rather than escalating to insulin, which isn't warranted here, we're initiating a GLP-1 receptor agonist because it not only lowers A1C effectively, but also supports weight loss, which could further benefit her glucose control. This choice aligns with ADA guidelines and considers both her clinical profile and long-term risk reduction goals. These lifestyle recommendations are just as essential as pharmacological ones, especially in someone like this patient who's motivated and already functioning at a high level. Setting clear activity and weight loss goals gives her measurable targets, while routine screenings like foot and retinal exams help us stay ahead of complications. This part of the plan really ties prevention and patient engagement together. So we have nutrition, and there's referral, increasing her physical activity, 150 minutes per week. Um, we have a goal of 5 to 10% weight loss within 6 months. And preventative, we have A1C recheck in 3 months, annual retinal and foot exams, and monitor lipids. This part of the visit was more of a conversation than a lecture. Talked about how GLP-1 meds actually work and what side effects to look out for. She seemed interested and asked good questions, which made it easy to go over things like checking her sugar, knowing when to call us, and just building better habits overall. It was a solid chance to reinforce that she's not just managing numbers, she's taking care of herself in a major way. So when we think of how type 2 diabetes typically shows up, we picture the more obvious symptoms like constant thirst, frequent urination, or numbness in the feet. This patient didn't come in with any of that. And that's kind of the point. Diabetes doesn't always wave a red flag. Her case is a reminder that things can still be slipping quietly in the background, and we have to stay tuned in when everything seems fine. Okay, and this is just a quick refresher on how diabetes is diagnosed. This patient doesn't need confirming labs. She already has the diagnosis. But what's important here is that her recent numbers tell us she's not quite where we want her to be. This is less about identifying the disease and more about recognizing when we need to adjust the course or strengthen the current approach. When it comes to picking next steps for meds, the ADA 2024 guidelines give us a lot of flexibility. Since she's already on metformin and her A1C is still above goal, it makes sense to add something. A GLP-1 checks a lot of boxes: weight, cardiovascular protection, and minimal risk of hypoglycemia. That said, other options could be considered depending on cost, renal function, or patient preference. Excuse me. Okay, these are a few red flags. These are things we always have to keep in the back of our minds. Signs that a patient's diabetes may be progressing or complications are setting in. This patient didn't show any of these, but knowing what to look for helps us stay ahead. Even something like a small foot wound or blurred vision can be a turning point if it's not addressed early. Okay, I included these questions to reflect the kind of decisions we face in real practice. The focus on treatment steps, test interpretation, and lifestyle advice based on current standards. I'll hold off on posting the answers until everyone's had a chance to weigh in as Professor Koval's instructions. The questions are: what is the appropriate initial pharmacologic treatment for a newly diagnosed patient with type 2 diabetes mellitus and an A1C of 7.5%? Question 2, what is the most appropriate next step in a patient currently taking metformin who presents with an A1C of 7.9%? Which laboratory test result best indicates the presence of early diabetic nephropathy? Question 4, what is the primary mechanism of action of GLP-1 receptor agonists in the treatment of type 2 diabetes mellitus? And last question, which lifestyle intervention is most effective in reducing insulin resistance in patients with type 2 diabetes mellitus? To wrap up, this case served as a good reminder that even a simple check-in can reveal a lot when we slow down and listen. It's not just about adjusting meds or ordering labs. It's about catching patterns and making sure the plan still fits where the patient is right now. Thanks for following along. Looking forward to the discussion and on Blackboard. Thank you.